Good morning. My name is Maureen Rosette, and I am a citizen of the Chippewa Cree Nation in Rocky Boy, Montana. I'm also the president of the National Council of Urban Indian Health, which represents 42 urban Indian health programs across the country who provide high-quality, culturally competent care to urban Indians who constitute up to 70 to 78% of all American Indian Alaska Natives. Thank you to the Chair and Ranking Member for holding this public witness hearing, and hope this year is the year we will truly see funding level changes. My testimony today will mainly focus on the Indian Health Services. I first mentioned the urban Indian topic. That term refers to any American Indian Alaska Native who's not living on the reservation either permanently or temporarily for a variety of reasons, but often because of the federal government's forced relocation policies or in search of economic and educational opportunities. Congress has long recognized that the federal government's obligation to provide health care for American Indian Alaska Native people follows them off the reservation. Recently, CMS, Center for Medicare and Medicaid Services, made a decision regarding the Arizona 1115 waiver to use the narrowest definition possible of American Indian Alaska Native for Medicaid work requirements. This is despite the fact that Congress stated that the purpose of the Indian Healthcare Improvement Act was to ensure the highest possible health status for Indians and urban Indians and to provide all necessary resources to effect that policy. CMS ignored centuries of law and extremely narrowed the American Indian Alaska Native definition, which will hinder access to care across the country and further burden an already overwhelmed and underfunded Indian health service system. I'd like to start by thanking you and offering my deep appreciation for the subcommittee's strong leadership and continued support for Indian health care. NCUI has several recommendations for the FY20. One is to increase the urban Indian line item for IHS. Less than 1% of the IHS budget is set aside for urban Indians who are urban Indian programs. And as you may or may not know, there's up to 70% of all American Indian Alaska Natives are urban. Urban Indian health programs do not have access to other line items throughout the IHS budget. The 42 urban Indian health programs operate with 1% of IHS budget funding, which is approximately $51.3 million. Thank you for the $2 million increase in our line item. However, we do not believe that the solution is to take money from the tribes to address the unmet need of urban Indians. Rather, IHS's overall budget must be increased in order to allow the agency to, among other things, better serve American Indian and Alaska Native people who live in all areas. Tribes have requested our line item to increase to $81 million, which we are eternally grateful for. We would request that the IHS budget increase our line item to at least 2%, which would be about $116 million. While this is just a sliver of the money Congress appropriates yearly, it would make a significant difference in our communities. Presently, urban Indian health programs and their staff are forced to deal with incredibly tight budgets. In this last shutdown, 2 of our programs had to completely shut down. 3 of them had to reduce hours as well as lay off staff. 6 programs had reported that they would only be able to stay open for an additional 30 days. Our UIHPs go to great lengths to provide care in Indian country. Some have even had to take in personal liens on their homes to assist with their facilities. Congress cannot continue to let this happen and must create true parity for urban Indian health programs. We have a program in Minneapolis, Minnesota, for instance, where we have a homeless crisis for American Indian Alaska Native people, many of whom suffer from diseases, addiction, and other serious health complications associated with homelessness. Increased funding is needed to combat the senseless deaths of vulnerable urban Indian communities. Our programs are in need of real funding to tackle these very real issues. In addition, IHS is considering moving its behavioral health initiatives from grants to direct distribution through the Indian Self-Determination Education and Assistance Act contracts and compacts, for which UIHP's urban Indian health programs are not eligible. Urban Indian organizations currently only receive $5.9 million in these grants, which fund vital behavioral health services. As a whole, by inadequately funding IHS, Congress has put the federal government in clear violation of the trust responsibility to provide health care to all American and Alaska Native people. We know the lawmakers on this subcommittee have fought for more IHS funding, and Nikui wishes to express our profound thanks for those efforts. We'd also like to protect IHS from funding uncertainties. As I stated more than once, UIHPs are their funding for UIHPs are severely limited. When that funding is delayed or cut off in the event of funding uncertainties such as government shutdowns, UIHPs suffer greatly. It is for this reason IHS and Indian health programs must receive advance appropriations. According to the survey of UIHPs, and the rising frequency of shutdowns and funding delays, many of UIHPs have begun to set aside funding in the event of a further shutdown. This is funding that we actually need for our programs, which we shouldn't have to worry about further shutdowns. We also would like to recommend
I have to.
Oh. Okay.
Thank you.
All right. Thank you.
Thank you.